We change gears a bit. We come to imaging. So the next speaker is Jordi Díaz-Manera, now from Newcastle, formerly from Barcelona. And Jordi will give us his thoughts on imaging with the MRI technology. And who else could speak on this like you, Tom?
Thank you very much, Benedict. So, well, I'm going to start with, first of all, I would like to thank the organizers for inviting me. I have really enjoyed yesterday the rodeo. I hope that you enjoyed this talk as much as I enjoyed yesterday the rodeo. So, and I'm also very excited to be here for the first time. I'm going to talk about muscle MRI in Pompe, and I always start with this slide. So some of you have seen this slide several times already, but I think it's very useful and very important to set the ground. So we are going to talk about a technique that what is trying to do is to look at what happens in the muscle from a structural point of view. So we need to understand what are the changes that happen in the muscle from a structural point of view in patients with Pompe, because this is what we can investigate. So we know that we start with a muscle that we can consider healthy, that is going to start accumulating glycogen, and this is going to lead to, through different mechanisms, to the death of muscle fibers and the substitution of these fibers by fibrotic and fat tissue, right? So if we want to study this with MRI, there are some well-developed and well-known technologies now that imaging sequences that we can apply. So fatty replacement can be easily studied using T1 or quantified using, for example, Dixon. And I think that it is useful for you to understand that MRI, it's a useful tool in Pompe because can help in the diagnosis. Because we know that in neuromuscular diseases, the muscles that are affected are not randomly affected. Depending on the disease that you have, there are some muscles that are affected and others that are spared. And therefore, what we did was to study what was the pattern of muscle involvement in patients with Pompe. And this was our first study that we published in 2016. This was a collaborative study that we did in Spain, where we scanned 36 patients with Pompe disease. Some of them were affected, while others were pre-symptomatic. And we came up with this nice heat map that is showing you in different colors the muscles that were more affected. So the darker the color is, the more affected the muscle is. So we realized that there was a group of muscles that were more affected than others, and these muscles were the tongue muscle, the suprascapularis muscle. We observed that there was a predominant involvement of the trunk muscles, especially the abdominal muscles and the paraspinal muscle. And there were also others that were affected, like, for example, the dorsalis muscle that was associated with this scapular winging that you can see here. So if we go to the lower limbs, we observed that there were, again, muscles that were more affected than others, and these were the trunk, the muscles again, the psoas muscle, the glutei muscle that are severely affected in patients with this disease. We observed that there was an early involvement of the adductor magnus, which is, I don't know if I can show here. You can see the adductor magnus that is very characteristically affected in this disease. And then the posterior muscles of the thighs. And you can see again another example. And just late on the disease progression, we observe an involvement of the anterior muscles of the thighs. And please keep this data now in your mind, because this is something that we will discuss later. And we observed that the distal muscles of the legs were normal. So this is what we call the Pompe pattern, and was useful and has been useful for many years to diagnose patients. So now we have diagnosis that can be done with a panel of genes, very easy. But in the old times, not so many years ago, we were using Sanger analysis, doing gene by gene, and then having a pattern like this was useful for the diagnosis, right? So this is the first thing. I think MRI is useful, still useful for diagnosis, but it's also useful because correlates with muscle function. So I have some videos here. Let's see if we can see the videos. I probably need you guys to press the video, the play. So you all know that this is just an image is better than 1,000 words. We say this in Spanish, right? And what you know is that patients with Pompe, they have a typical gait, something that you can see most of the. Can you click all the videos? You can see the patients walking here.
Si está saliendo, llama se te oye.
Sorry, this is my voice. And if you look at this characteristic pattern of gait, you can identify that they have this Trendelenburg gait.
Mira, Vial, ara quan arribis davant de la taula, et demanaré que et posis com de perfil, mirant cap allà,
it's better if you stop the voice. And then you can see that in the MRIs of these patients, what we observe is that there is a severe involvement of the paraspinal and abdominal muscles, and severe involvement of the glutei, which are justifying the way how patients walk. So once we what happened now? Okay. Once we saw this, then we said, okay, let's try to quantify or try to correlate if there is a good correlation between amount of fat in the muscle and muscle function. And we used several of the tests that are done in clinical trials. You can see a table here. And we correlate this with the amount of fat that patient had in the lower limbs. And we observed that in general, there was a good correlation. That was not perfect, of course, but most of the tests correlated well. So having fat matters because correlates with loss of muscle function. So why is MRI useful? It's useful as well for the follow-up. And in the last 10 years, there have been a lot of papers describing this imaging sequence called Dixon. That is something that we have been starting to use in neuromuscular diseases. So what Dixon does is that it gives you two images of the muscle, one that is the water and one that is fat. So we can then draw a region of interest, as you can see here on the left, and then we can get information about that region of interest, the area and the percentage of fat, exact number, 23.4%, for example, here. We can draw many regions of interest. We can study the whole leg, the whole thigh, or just individual muscles, and came out what we call the fat fraction, which means the mean amount of fat that is present in the thigh, for example, or the leg. And this is useful because if we follow our patients over time, what we have seen is that, okay, if I draw, for example, my region of interest here, identify that this region has 49%. If I move this 1 year, and draw the same region, I identify that is 51.2%, which my eye would never be able to catch. So that this increase in 2%, it's impossible that we realize just looking at the MRI. But with this sequence, with these softwares, we can. And we can see that there was an increase in 2%, which suggests that patients have worsened just a bit, just 2% after 1 year. So what we did was to study lots of patients, around 30 patients with Pompe disease for 1 year, using multiple different tests, using muscle function tests, using respiratory function tests, quality of life, and also MRI. And it came out that the only measure that shows significant changes in patients with Pompe that were treated with myozyme at that moment was MRI. So muscle function was not detecting any change, but with MRI we were able to detect changes earlier in disease progression. And interestingly, when we continued to study this patient, we saw that the increase in fat was very stable, around 2% per year, and that we could observe that there was a huge variability, as you can see here in this graph, between some of the patients. So in red, you can see patients that were symptomatic and treated. Some of them worsened at 13%, so increased 13% amount of fat, while others just increased 2% in 3 years. Why is this happening? We don't really know. We look at many factors that could be influencing this response, and the only thing that we identified that was relevant is the baseline fat fraction. So the more fat you have at baseline, the worse it is for your progression over 3 years of time. And then I want to ask you to start looking at these other colors, the blue ones and the yellow ones, because these are presymptomatic patients. And we observe that in some presymptomatic patients, fat can also increase. And then there is also always this question in the audience, that is, how relevant this is? Well, we observe that increasing fat fraction, in the end, impacted muscle function. So if you have patients that have increased 10%, we observe that the muscle strength is worsening. So fat fraction can be then a predictor of what is going to happen to a patient. Of course, it's not good that you accumulate fat, because in the end, you accumulate fat because you lose muscle fibers. And if you lose muscle fibers, in the end, you lose muscle strength and function. And this is just to show you that after 3 years in some of the patients, our eyes were finally able to identify some differences in some of the muscles. You can see here baseline semitendinosus, and after 3 years, that was much replaced by fat. Okay? This is useful as well to support treatment decisions, and this has been a fight during many years to convince people that MRI is useful. And I think it is very useful. So here in this first graph, I show you this heat map. This group here, that are the orange patients, are presymptomatic. And if you look at the colors, you can see that, oh, well, look at this. Some of the patients have some changes here. There was some fat in some of the muscles. So if we were interested in looking into this in more detail, and these are the 6 patients that were, in theory, pre-symptomatic in our cohort. And you can see that if we look at the paraspinal muscles, 3 of the patients, the younger one, were completely normal. You have this nice big paraspinal muscle. Here you have this lady, 26-year-old. You start seeing some fat here, 39, much more fat, and this gentleman, 51 years old, and the paraspinal were completely replaced. What else can we look at? We can look at the adductor magnus. I have already mentioned this muscle that for a reason that I don't know gets affected very soon and is not only replaced by fat, it's completely atrophic, it's gone. And this is something that we can see again in these patients that were having late onset Pompe disease, but they were not so young. So I would like you to press the video again. And this is, I have shown this video several times, so this patient is now familiar for some of you, but this is someone that said, I don't have any problem. I can do my life completely normal. I am pre-symptomatic, okay. And when we look at the muscle biopsy, the muscle MRI, sorry, this is the muscle MRI of this patient. There was lots of fat. So this was a few years ago. Now this patient is treated and he uses a stick for walking. So I think it is important to bear in mind that having fat again, and insisting this, is not free. So you have consequences. But is fat the answer to everything? No. That's an important point as well. We have also analyzed a lot of juvenile patients that have started showing symptoms, and in many occasions we don't see fat. What is happening there? I don't know. I think that probably there is an increase in the glycogen, or maybe there are some fibers that are start to die, and that's the reason why patients start with symptoms. But with these juvenile, these teenagers, not always there is fat in the muscle. So we got interested in glycogen. Can we study the glycogen? Is glycogen going to give us the answer for these patients? So can we study glycogen with MRI? Yes, there are some new techniques, and this is now a trendy topic. There are lots of groups working in this glycocyst and glyconoe that I am not very familiar with. So I'm going to talk a bit carbon spectroscopy. And one of the good things of moving to Newcastle is that I could start working with this person here, Pete Thilwell, who is professor of physics and works in the MRI, and he developed carbon spectroscopy in Florida and now in Newcastle. So what we have done with Pete is to use this coil that you can see here. This is a carbon coil that can detect the carbon atoms in the muscle. And what we want to study is the first carbon of glycogen, which is this structure here. So what we are going to get, oh wow, what happened? I think I had a picture. Well, no worries. So this, what we are going to get when we do, what happened? When we do carbon spectroscopy is that we get this spectrum here. And what we are looking is at this peak. So this is the peak of the glycogen. This is telling you how much glycogen do you have in a structure, in a tissue, or for example here in a phantom, which is a bottle that have a concentration that we know how much glycogen is in there. So based on these first studies where we used that coil, we started using phantoms, and we realized that we can measure glycogen, we decided to do this study, which is a 2 years follow-up study funded by Sanofi, where we are including not only asymptomatic, early symptomatic patients, and we are doing MRI with a 3 Teslas MRI. This is an important point. We want to be sure that we can develop something that can be applied in hospitals that have 3 Teslas MRI, which is a conventional MRI, and not only work with 7 Teslas MRI, which is the much more powerful but only present in research centers. So we did this study with 3 Teslas MRI, lots of new muscle function tests trying to identify early damage in some patients, and also blood analysis. And what I'm going to show you is some of the preliminary results. So far, thanks to Mark Roberts, that has sent a lot of patients to Newcastle, so thank you, Mark. We have included 10 patients and 9 controls. There are no gender or age differences. Most of the patients were in early stages of the disease, but I can tell you that we have started including patients that are not so early because we have more answers more questions that we want to answer. So you can see here the medium air packed and the NSAD, that there is a bit of variability, but most of the patients are in the mild range of the disease. Just to show you the fat fraction, you can see that these are some examples. Most of the patients are already early, but I want to show you that we have also included patients that have a lot of fat because we wanted to know what happens with fat and glycogen. And well, this is just to show you some examples. So this is a control, and what we are looking here is at the fat quantification, the glycogen quantification. This is the spectrum that we get, and you can see here that we were supposed to have a peak here, and we don't see too much. But the amount, this is what you see in a control. This is what we see in a patient with Pompe. This is the anterior muscle, and here you can now identify that there is this tiny peak in the spectra, that's a glycogen. And if we go to the posterior muscles of the thighs, the peak is clearly higher. So we can start seeing this peak with much more clarity. So one of the things that we have realized is that there are differences in the amount of glycogen between muscles. It's not something as standard. And it seems that there is more glycogen in the posterior muscle than in the anterior. And these are, again, please bear in mind, these are just work in progress, but some of our results. And then we have seen that when we compare controls, the blue with the orange, which are Pompe, in the anterior part of the thigh, the vastus lateralis, we don't see many differences. When we go to the posterior muscles, we start seeing differences between the Pompe and the controls with higher levels in the Pompe. Why is this happening? Again, I don't know. Is this related with the fact that the posterior muscles are going to be affected earlier in disease progression? Maybe, but I'm not sure of that. But we have not identified any correlation between glycogen and fat fraction or water tissue time, which it's a measure of edema. Also, this study is not powered to identify correlation between these because, as you have seen, many of our patients had very low levels of fat fraction. And we have not identified any correlation between muscle function and glycogen content at baseline. So we need more work and see if this glycogen predicts changes in muscle function over the years. So just to show you, last slide that is worrying me a bit, this is a patient that have a lot of fat, as you can see in the posterior muscles, and when we go there, we cannot identify in a signal. So having fat, of course, leads to loss of muscle fibers and leads to loss of glycogen. So this is very relevant because patients that we are going to put in trials, if we want to start using this technique in trials to monitor glycogen, patients have fat in the muscle. So this can be one of the limitations that we need to take into account. Of course, needs a lot of work to be done and try to identify other muscles that can be reporters of the amount of glycogen that the patient has. So conclusions, I hope I have convinced you MRI is useful. It's useful for the diagnosis, it's useful for the follow-up, and it's useful also to decide to treat a patient. And I think that carbon spectroscopy can be useful, of course. We know that we can detect glycogen, but I think that there is still a lot of work to do to know if this is a good biomarker to follow up our patients in clinics or in trials. And I would like to thank everybody in Newcastle. This is my email and my Twitter account, and thank you very much for your attention.
Thanks so much, Jordi. Excellent talk.